Good evening, everybody. We'll give everyone just a few minutes to get connected. Okay, in the interest of time, we'll go ahead and get started. Welcome, good evening to our 8th speed session for the Society of Pediatric Echo Education. Tonight, we will have a Z-Score Journal Club for everyone to enjoy and comment on. Our first presenter is Ray Lorenzoni. Ray, who you may know by his Twitter handle, Dr. Baby Hearts, is a New York City trained pediatrician and pediatric cardiologist currently finishing his advanced imaging training at the Children's Hospital Los Angeles Heart Institute. He is intent on improving our understanding and communication of congenital heart disease through his research and education using 2D and 3D cardiac visualization. After training, he is excited to be joining the faculty at Connecticut Children's Health System and the University of Connecticut School of Medicine as a multimodality imager. His conflicts of interest include an advisory board position on a 3D imaging software engineering company, Microscape Inc. Take it away, Dr. Lorenzoni.
Ray, I believe you're still muted.
Thank you so much. Thank you for the wonderful introduction. I'm happy to be here and privileged to be speaking to you all. I'm going to be talking about coronary Z-score discrepancies in particular. Some of the topics about Z-scores in the discussion at the end will likely be more broad, and Dr. Margarete will talk more broadly about Z-scores in general. But coronary Z-scores have given us a little bit of a headache, probably because they are a bit variable depending on size of the patient and because of their small size themselves. So just to stay on topic, make sure I am hitting all my points. We're going to be talking about why we use Z-scores in the first place, just briefly talk about the article that I'll be discussing today that was published just a year ago, implications related to the findings of the article, and then what's next. And at the very end, we'll talk a little bit more about all these discussions. So why is Z-scores? Most of us know this. Kids are not small adults. They grow over time. And so the coronaries growing with them, a normal coronary for a 6-month-old will not be the same as that for a 6-year-old. And Z-scores tell you how many standard deviations from the mean, a raw measurement across a normal distribution, how many standard deviations a measurement is from the mean. Across the normal distribution, and for certain populations you correct based on body size or another characteristic in order to fit a line to the curve, and we'll talk about that more in a moment. And so transforming the data across the population can be done based on age, height, weight, gender, BMI, BSA, etc. And we typically use BSA for most of our Z-scores, and we will talk about whether that is always appropriate or if other parameters might be a better estimation of some of our measurements. This is the basic formula that we see here at the bottom for Z-scores, and it looks relatively simple. Z-scores are based on the population mean minus the patient measurement over the standard deviation. But most of you may know that in many of our publications, they look a little bit more complicated, and this is because of that transformation that happens in order to accommodate for growth in a way that reduces the variability between measurements and makes predictions more accurate. This is variably successful depending on what you're measuring. Coronary arteries have had a little bit of an issue. There's been an issue measuring coronary arteries at certain extremes of BSA or Z-score, and there are various models to account for that. You'll notice that some of our models, correct for BSA in both the standard deviation as well as the calculation of the mean. the difference between the mean and the measurement. But some do not. So these are 4 different, North American z-scores, which the paper that I discuss will address. And the reason that we need many of these corrections is because there are a number of issues with the distribution of measured parameters, coronary measurements being one in particular, and that variability across a population is called heteroscedasticity. And heteroscedasticity is, you can see, compared to a more normal distribution that does not have variability across its distribution. Basically, the variance around your line of regression changes over the course of the population, as opposed to a relatively normal distribution where the variance across the distribution is the same. The variance around the regression line is the same across the distribution. And regression equations that are based on homoscedasticity as opposed to heteroscedasticity tend to predict measurements a little bit better. They are closer to the line. You know a little bit better how far away from the line at most a measurement could be. But many of our measurements don't follow that trend, and we'll talk about why that's important. And so, yeah, these just depict the variance in the variance around the regression line. And so, let's see here. And so there are a number of types of z-score systems. These are just the ones for coronary arteries, and I don't need to go into depth into all of these because it's kind of a busy slide. But this is just to depict and show everyone that there are different ways to correct for some of these issues that we encounter, and different groups have done so differently. And the most recent attempt at a comprehensive z-score system in North America was with the PHN group, with Leo Lopez and everyone there. And everyone involved with that study. Was a multi-site study that had over 3,000 patients. And this was an attempt to standardize the z-score system. And when compared to other z-score systems, unfortunately, a few more questions were raised than otherwise. And so the PHN z-score system, although comprehensive and very detailed, has not yet been taken up in force. Most institutions across the country still use the Boston system, and some use the DC system and Montreal system, at least in North America. In East Asia and countries more affected by Kawasaki disease, they tend to use their own z-score systems, and those are population specific. The ones I mentioned first are more North American. We have a Italian group by Cantonati, and then there are Japanese and Chinese groups. The article I'm going to be discussing is Impact of Z-score System on the Management of Coronary Artery Lesions in Kawasaki Disease, which we published, both Dr. Margarete and I, in addition to a number of our other collaborators, including Nadine Schwader from Montefiore, at about a year ago. This was published in Cardiology in the Young. And what we sought to do was use a large, more or less real-world group of patients and have those patients' coronary measurements calculated for each Z-score system. And then we would compare the results. We would compare, what these patients' Z-score value would be for PHN versus Montreal versus versus the DC systems in Boston. Boston being most prevalent, and so we focused on that and compared the others to Boston a little bit more than comparing the others to themselves. And in order to get this large cohort, we combined the over 100 patients we had over the last 10 years from Montefiore that were standardized to the NHLBI Kawasaki disease study that's publicly available as a data set. And that resulted in the 333 number. Luckily, those patients were, luckily the measurements and the patients themselves were largely similar, and we were able to compare those two populations as one cohort. The main differences with the Children's Hospital at Montefiore being in the New York City area is that ethnicity and race were a bit different, and there are minor differences between race and ethnicity when you're measuring Z-scores, but those are fairly minor and not thought to be clinically significant. But there were no differences in measured Z-score groups, and so the number of patients or the percentage of patients in each of the coronary artery sizes, that is, whether they're dilated, small, medium, large, or normal, were not different between the two groups. We used the AHA Kawasaki disease guidelines, the simplified definition for coronary lesions, and that's listed here. And I say simplified because coronary aneurysms in particular, it's not just the absolute size of them. Traditionally, we also look at the size of the aneurysm compared to a neighboring segment of the coronary, and then also there are histologic and kind of 2D characteristics that you can use to identify aneurysms as opposed to just broadly dilated coronaries. But for these purposes, in this Kawasaki population, we use the simplified research definitions that that the AHA has put out. There are a few there were a few large coronary aneurysms in the combined data set, just 2 or 3, I believe, in my memory. And so we weren't able to do analysis on this group of patients, but we still found some interesting findings. Getting to those, when comparing, this is a little bit of a busy slide, but we looked at both measurements on initial evaluation of acute Kawasaki disease and 6 to 8 week follow-up, which was typical for our center as well as the multi-site NHLBI study. What we found was at the initial evaluation, there was a distribution of Z-scores. And so white is normal. So this is our entire patient population. White is normal, yellow are dilated lesions, anything larger than a Z-score of 2.0 to 2.5. Our red value is greater than, is a Z-score of kind of a small aneurysm size, 2.5 to 5. Our brown color here is a Z-score of 5 to 10, which would be considered moderate or medium size aneurysm. And then the black lines, which are barely visible because there was a low number, is a Z-score greater than 10. Many of our outcome studies talk about a Z-score greater than 10 as having clinical significance, but there are management decisions that happen in between dilation and large aneurysms where anticoagulation may or may not be used, or dual antiplatelet therapy may be used, depending on local practices. And so we wanted to take a closer look at this and see what was driving these differences. And so we can see that across, the Boston system compared to the PHN system and Montreal and DC, there are large differences in whether dilation is diagnosed or not, whether small or medium aneurysms are diagnosed or not. The largest, the system that diagnoses the most lesions, quote unquote lesions, anything with a Z-score greater than 2, which would be dilation, is the PHN system. And those that diagnosed the fewest were the DC and Boston systems, with Montreal somewhere in the middle. At follow-up, these patterns were similar, but there was regression of coronary dilation, and so all of the numbers are lower across those, and we'll talk about what might be driving those on the next slide. Here is a breakdown of Z-scores by segment, and so each of the colors represents a different Z-score system, and we look at which Z-score system tends to diagnose more in which coronary artery segment. And so for the left main coronary artery, we saw that the Montreal equations tended to diagnose aneurysms. So these are Z-scores actually greater than 2.5 in this case. Actually diagnosed aneurysms to a much higher and statistically significant extent more than all the other systems. For the left anterior descending, PHN was the highest in this respect, and the fact that PHN diagnosed the most dilation or aneurysms seemed to be being driven by this left anterior descending equation. And then lastly, Boston marginally diagnosed more right coronary artery aneurysms compared to the other Z-score systems, with the exception of Montreal, which was not statistically significant. And so what does this all mean? What impact is that going to have on management? This is a pairwise comparison of Z-score systems. These are just some select examples because comparing all of them would take all night. But PHN versus Boston shows actually a pretty consistent Z-score difference across the entire population of BSA. And so when we look at Z-scores, the Z-score numbers actually here at the bottom. When you have a Z-score of 10, the PHN diagnoses when you have a Boston z-score of 10, the PHN z-score is 11.3. And actually that difference is very consistent across the entire range of z-scores. We see that there's a line that's just above this line, which represents the Boston line in the middle, kind of our identity line. And this is for the left anterior descending. And this is the main finding that we saw in the last slide, where consistently PHN was diagnosing aneurysms to a greater extent in the left anterior descending. When we compare DC versus PHN, again, the correlation coefficient for this is a little bit lower, and that is because we see, as compared to our identity line, that DC tends to veer off below the PHN, meaning that DC diagnoses fewer aneurysms. We have similar kind of discrepancies in some of these other systems. We'll notice that the correlation coefficient is actually really high for many of these systems, but these still had clinically significant differences in anticoagulation, which I'll show in just a moment. In terms of, these are just Bland-Altman comparisons, which are actually showing the statistically significant differences. So even though our correlation coefficients showed relatively good reproducibility and reliability, our Bland-Altman, essentially inter-rater reliability, showed that there were statistically significant differences in Boston versus Montreal, PHN versus Montreal, Boston versus PHN, and PHN versus DC. And what does that mean clinically? So if we use Boston as the baseline, since that is likely the most commonly used z-score system in North America, we see that if we were to take a patient who had been diagnosed using Boston's z-score system, and then at follow-up, or even at the same time, if nothing else had changed, but we apply a different z-score system, DC would indicate 2% more anticoagulation if we use the definition in the AHA guidelines of either aspirin or dual platelet anticoagulation, 2% more than Boston. Montreal would indicate 9% more patients to have anticoagulation, and PHN 20 to 22% more, depending how you look at it, anticoagulation. And this is not 20% more compared to Boston. This is 20% of the population, and so more than double what Boston would have prescribed, more than double what the Boston system would have prescribed. And so this is a significant difference, and something that we really have to work out. Going back to our theory and the way that z-scores are arrived at is a little bit arbitrary, in that you use a population and then you modify, basically you mathematically transform that population using either a logarithmic scale or a parametric scale or a simple square root. And you basically fit a regression line to that, and then you see which regression line fits best with your population. And some groups have done that, using just that methodology. Some have added kind of ease of use and ease of the mathematics to arrive at their methodology. And so there's not consistent agreement about how to create z-scores. And this is, this mathematical difference, in addition to population differences, are reasons why we see some of these clinical discrepancies when using different systems. And as I alluded to earlier, heteroscedasticity is unequal variance. Having high heteroscedasticity indicates residual dependent effects that are not accounted for by the model, and so transformation tries to minimize that, and this decreases accuracy of z-score predictions. And so what are the implications? I talked a little bit about the clinical implications, but even transforming these z-score models non-uniformly across different research groups, results in inconsistent model creation and kind of important clinical differences, as we've seen. In addition to that, it's not just that we need to compare z-score models to one another, because even when you have high correlation between z-score models, where they're statistically highly correlated, we still see clinical differences, which is what our study showed. And so kind of as the inverse of the common wisdom that statistical significance does not equal clinical significance. This is the inverse, in that statistical non-significance does not necessarily equal clinical non-significance. And so what's next? And this kind of feeds into what Dr. Magarefte is going to discuss, which is that several Z-score models show clinical variability, and even with better outcomes data to kind of ground and align our models to outcomes, high heteroscedasticity still makes these models sensitive to measurement error and small changes in coronary Z-score. And so what is the ideal Z-score model? And I'll stop here and let Dr. Magarefte continue.
All right, thank you, Ray. Joan and I would like to remind everybody, if you have any questions, to put them in the chat. We will be monitoring that. And I'm happy to introduce our next speaker. Dr. Joseph Magarefte is an associate professor of pediatrics at the Icahn School of Medicine at Mount Sinai and director of preventative cardiology at the Mount Sinai Kravis Children's Heart Center. In addition to preventative cardiology, he's interested in quantitative echocardiography research. Dr. Magarefte received his medical degree from the Isfahan University of Medical Sciences in Isfahan, Iran. He performed his residency in pediatrics at Children's Hospital at Maimonides Medical Center and his pediatric cardiology fellowship at the Children's Hospital of Montefiore, Albert Einstein College of Medicine. Welcome.
Thank you, Carolyn. Good evening. I'm honored to present here tonight, and I want to thank all the organizers for giving me such an opportunity to present our research. I'm going to present our height normalization paper that was done with Pediatric Heart Network team, and I should thank and acknowledge all my co-authors, specifically our co-writing group, Dr. Lopez, Dr. Cole, and Dr. Lai, that helped in forming this analysis and writing this paper. Our title was Height versus Body Surface Area to Normalize Cardiovascular Measurement in Children Using the Pediatric Heart Network Echocardiographic Z-Score Database. This is a complex topic, and I will try to present a summary of this paper in the next 8 to 10 minutes. What is Z-score or normalization, and why do we need to use it? Ray already alluded to it, that normalization of the size of cardiovascular structures allows for comparison of measurement among children with different body sizes. It accounts for the physiologic effect of somatic growth and highlight the pathologic impact of disease processes that are going on. The primary goal of our paper was to compare the performance of height and body surface area for normalization in a group of normal children with no obesity. I have to mention that the debate of which method to use in obese patients is a long-standing, and it's something that we could not resolve and we were not planning to solve by this study. But the idea was this, that clarifying the differences in normal weight patient, in normal body composition patient will be a step to help in future research. As I already mentioned, this was a secondary analysis of a subset of patients from the cohort of Pediatric Heart Network EchoZ-Score database. Pediatric Heart Network EchoZ-Score database was a study of normal echocardiogram, as Ray mentioned, 3,200 echoes from 19 centers across North America, and from the children with no comorbidities, specifically no obesity, no hypertension. And this cohort was unique in a way that we had an equal distribution of gender and race across all the pediatric age groups. We included children over the age of 2 because of the definition of obesity and overweight. It's more clear in that age range, and compared the height and BSA normalization for aortic annulus, root, ascending aorta, and left ventricular end diastolic volume and mass as a prototype of the measurements that we wanted to do. Again, I have to mention that there was nobody in this database was obese, so we were working with the normal weight population, some to be overweight, some to be underweight, but nobody was in the obese population. Now, we did the same methodology that we did in the original Pediatric Heart Network Z-Score study that when the BSA normalization was published, and we followed the same model characteristic. For a z-score to be an appropriate z-score, we believe that normalization is appropriate if we can follow these three rules for the normalization. Number one, there should be a linear relationship between the measure and the body surface area or height in whatever allometric power we were using. Number two, the index parameter of this measure divided by our BSA or height in that allometric power should be normally distributed. And last but not least, that there was no clinically significant residual dependence of the index parameter on body surface area or height, i.e. that there is a zero slope of the index parameter in the is plotted against the height or BSA. No, this last portion is what often confuse trainees, and when we talk about it, it's difficult to follow, and Ray alluded to it again a little bit, but I'm gonna go through it a little bit further. This is from a paper that was published by Dr. Colan originally when they came up with an allometric normalization model. As we see here, aortic annulus and body surface area, they correlate very well. But if we divide annulus by body surface area and plot that against the body surface area range, we still have a residual relationship with body surface area. That is against what we were trying to do, to come up with a mean and a standard deviation and use it across body surface area range. So what allometric normalization does is that we use a power of that parameter, which in this case is body surface area. Here we use the square root of body surface area and aortic annulus. The correlation looks the same as the one on the top, but when you plot the aortic annulus divided by square root of body surface area versus body surface area, you have a flat line. There is no residual relationship. Now, if I use a mean of, let's say, 1.5 in this case and standard deviation, it works the same across all ranges of the body surface area that we have here. Now, I hope that this was clear, and I'm going to move on to my results. Here, I'm showing the correlations of the cardiovascular parameters that we did with the normalization by height and body surface area. And as we see, that these correlation factors, they were almost the same, and they're pretty high correlations, and there was no differences that we can see. And when we look at mean and standard deviation, one can say that it looks like that they're well normally distributed. And for that number 3, to say that if are we following that, losing that residual relationship, we use the methodology that we check the impact of that residual relationship at the first and the last quartile of the patients that they were in the study, and to see that what is the % impact of this residual relationship with whatever we are normalizing. And we decided on first paper and on this follow-up paper that anything below the level of the inter-observer variability measurement, variability of the measurement, which is for unidimensional parameters like annulus, aortic root, and ascending aorta, we decided 5%, and for calculated measure like volume and mass, less than 10%, it's not clinically significant to be important residual relationship. And as we see, these are all pretty the same and low, although that the height residual relationship was slightly higher than the BSA one, but within the realm of inter-observer variability that we're talking about. Now, we followed the same thing that we did in the original paper, and we went ahead and we checked the residual relationship with the age and gender and races of the patients, and trying to see if there is any significant residual relationship there. And again, with the same method, as you see, everything is below the level of inter-observer variability. for this measurement, implying that there is no need for further adjustment of the model based on age and race and sex of the patients for this model to work in the patient population. Now, here I'm getting to an interesting part of the paper. Here we decided to assess our residual relationship of the normalized values with body mass index Z-score. Body mass index was used as an index of adiposity. And here in these graphs, the blue demonstrates the height-based normalization, and the red is the BSA-based normalization. And as you see, the direction is different. The blue is going upward as we're going on the higher level of BMI, and the red is going downward as we're going in a higher level of BMI. That means that if the patient has a higher BMI, height normalization would result in higher Z-score, and vice versa, BSA normalization would result in lower Z-score. But again here, when we check the this residual relationship that I was just showing here, that there is still a relationship and there is a slope, the impact of that residual relationship was still very minimal. It's between 3% at most here for the left ventricular mass based on height to 0.8, 0.6% for aortic annulus, and root up to 1% differences. These are all very minimal differences that easily can be overlooked because of the inter-observer variability of the measures. Now, I mentioned at the start to say that the ideal Z-score needs to account for physiologic variable affecting cardiac size. These are age, gender, race, ethnicity, sex of the patients, which we already shown that both models, they pretty equal in that performance. But on the other side of it, the Z-score should be able to identify pathologies impact on the cardiac size, which the pathologies, as most of us dealing with congenital heart disease, is hemodynamic aberrations, blood pressure abnormalities, and abnormal body composition. It comes into the model. Now, when we deal with a patient with a normal body composition, there is about 25% of body mass. It's accounted by body fat. That is requiring about 6% of the cardiac output. Unfortunately, as you see here in this graph of the growth of the obesity in the population since 1963 to now, we're dealing with about 20% incidence of abnormal body composition, at least in the direction of the obesity. And I have to mention that in obesity, by definition, you have at least 35% excess fat for the body, which is this 20%, it's going to be 35%. Now, what's the impact of that in this 6% distribution of cardiac output? That makes this whole normalization in the patients with abnormal body composition to be complicated and difficult, and essentially brought out so much of attention and research that has been gone through it. But I already alluded to this, that I don't think that one size fits all is going to work in this case. I think that both methods perform well, and even though that mathematically body surface area may work better, but clinically, based on our results, both height and BSA in normal weight patients, essentially they perform the same. There's no significant differences. But it's important that when we're using them, know that we can't use one size fits all, and understand the strengths and weakness of each model and each methodology and use them appropriately. So I copy-pasted some of these from the paper that we wrote as the final word, that if the goal is to normalize the potential effect of fat mass and assess for effect of other pathology factors on the heart, then we may suggest that normalization based on body surface area may be more useful. If the goal is to preferentially evaluate the effect of lean mass over fat mass on cardiovascular growth, specifically when we're comparing normal weight to overweight patients, then normalization based on height may be more reasonable. What I think this study and it helped with our future studies is that this study empowering us to be able to quantify the differences between these models, and it will help in guiding clinical decision. In fact, often when I have a patient longitudinally I follow and they gain a significant weight and the Z-score is not changing across the over time as the patient, and it looks like that the patient has a bigger heart, but the Z-score is the same because now the patient is going from underweight to overweight or changing body composition. I often use the other one too to see that now if I use height, what happens with my Z-score, and trying to get both of them for my clinical decision to see that how I can approach this. Is it really different, and how much of it is because of the change in body composition and how much of it may be related to changing the physiology of, let's say, aortic regurgitation causing the end-diastolic volume to go up. But what Ray presented, it's a different aspect of this issue of Z-score, that now that we have all of these models, which one perform better to predict outcomes? When we were working on Ray paper, one of the main things was that now why we say that Z-score of 5 needs double anticoagulation. And in fact, interestingly, there is no data behind any of those things. We decided as a society that we're going to use this Z-score of 5 and we're going to do that. We asked together with Ray from Dr. Newberger, and she said that we don't have data to say that 5 is different and 3 is not, and higher or lower. And there's never been such a study done to predict clotting to say that from this number I'm going to do it double or not double. So we're going to need to move toward that, I think, toward this, that start looking at our outcome based on different models and see which one can present can predict the outcome better and from what cutoff versus what we have. Thank you very much, and I will be happy to take questions. Of course, I had to add something about obesity because I'm a preventive doctor.
Okay, we have a few moments if anyone has any comments or questions for either Dr. Lorenzoni or Dr. Margarefti.
Hi, John. This is Shabika.
Hello.
Hi. I really want to congratulate both the presenters. I really enjoyed the session, and I think you really both of you explained the whole concept of Z-scores and variability like really, really well. Joseph, I have a question for you. So in clinical practice, what do you actually use in the obese and hypertensive population? What Z-score or what methodology do you use to correct for mass, LV mass?
Hi, Shubi. Thank you for the question. So again, going back to that outcome data, I'm still stuck with my LV mass index in the power of 2.7 or LV mass index to the body surface area based on M mode, because that's what the guideline of the hypertension using for defining LVH, and all of the outcome data in adults so far has been based on that. But do I believe that that's more accurate? No, but I don't have outcome data based on either one of these methodologies that we're talking about.
Can I say something real quickly? It's Leo Lopez.
Hi, Leo.
Absolutely.
Guys, so I think, Joseph, you're absolutely correct, right? There's a difference between what we're defining as abnormal, whether it's hypertrophy or dilation of a coronary artery, and what the thresholds are for treatment. And so I think you answered it correctly, that whatever the studies are based on to guide clinical practice should be what should be used to determine what, how you're going to treat somebody. So for example, the Kawasaki coronary artery guidelines are based on the Boston Z-score, the Boston Z-scores. And so you should really just use the Boston Z-scores when you're making decisions on anticoagulation on those patients, because as you can see, none of these Z-score models are actually equal, or as equal as we would like it to be.
This is David Izan at Mount Sinai. Thank you very much for a great talk. To follow up Leo's comment then, can I ask the question to the senior people on the call, and you can decide if you're senior. Then do we have to start making, just maybe make a decision as to which is the best Z-score system out there, and start setting an expectation that studies going forward would use that particular one, or that they have to use even multiple, or radically thinking for the key studies, and we can decide what's key, we retrospectively decide that if we have a better Z-score system, that we go back at the data and cull the data again, re-quantify things to determine how to use this the new Z-score systems. Because if we feel like we're getting more robust Z-score systems going forward, we're only going to have this problem. And the only way to solve it is to set a standard in the future studies that we published.
Do I count as senior? Can I?
Yes.
Can I respond to that? I think there's no such, I don't think we have, the what is that called? The true universal Z-score. I don't think that exists, because nobody knows for sure what the right approach is. A lot of people, as Ray had said, a lot of people are using these statistical methods where you're using natural logarithms or polynomials or exponents. I mean, there's some data that suggests one might be more physiologically sound than the other, but at the end of the day, all of these Z-score models are based just on normal populations. And what we're doing is we're trying to apply it to these abnormal populations and saying, yeah, that makes sense, but it's still not perfect. So I don't know if there is such a thing as the absolute best Z-scores. I think we're getting closer to describing what the mean behavior is of any of these measurements by having bigger samples. But statistically speaking, we're still not perfect, right? Because we don't know what the right statistical approach is.
Not aiming for perfection, but just for iterative improvement. Does this mean, though, as we start to get larger cohorts to create Z-score systems going forward, that from a practical standpoint, we should think about incorporating in our labs, multiple Z-scores? And we've moved to having PHN and Boston in our lab, and the expectation is that prospectively that's going to be important when we start doing studies going forward.
I guess what I would say is I would encourage people to use, I'm biased, right, because of the PHN Z-scores, but I would encourage people to use that when doing clinical studies, any kind of research study, so that we can actually have outcomes that are based on that. But until that point, in clinical work, I think most people are still using, whatever it is that they were using before, and making clinical decisions based on that. We're still using the Boston Z-scores primarily for decisions here.
Thank you.
I would say, sorry, if I may, just to kind of lead into a slightly separate topic based on Dr. Izan's point. We have a number of variables that contribute to the size, and Dr. Magarefti alluded to this as well. A number of variables may contribute to the measurement of the size of different anatomical, parts of the heart. And, eventually, with a large enough data set, we could probably get an idea of a multivariable model that would reduce the variance around our regression line, account for multiple dependencies of coronary size, for example, or of aortic size, or of ventricular mass. And if we put that into something like a machine learning model or a complex CART analysis, we might be able to get to a place where we can better predict and more precisely predict what a given patient's abnormal would be.
Hi, this is Janina Ruda. Going back to LV mass, Question for Dr. McGrath. Do you use the height to the power 2.7 to all age groups, including children younger than 7? Some data suggests that it's not as accurate in this age group.
That's correct. So if I have such a young child that I am trying to decide that is there LVH or not in a hypertension population, for LV mass, Shubi's point was in hypertension population, then because of the significant heteroskedasticity that it's in the younger age group and the higher numbers are still normal, I go back to a Cincinnati paper that was written and came up with the 95th percentile and trying to extrapolate from that. Saying that now the cutoff value in the guideline is so high and it's set at 50 and 54 that essentially it's a severe hypertrophy. So whoever goes above that, it doesn't matter really what age it is, it's a bad hypertrophy. And we don't even need measurement for that. We can all look at that heart, which is 54, and say that this is real hypertrophy. It's more of a use in research purposes, I personally think. But I agree with you that in younger age, the higher LV mass index to the power of 2.7 still is normal, comparing to older teenagers and adults.
Thank you.
All right. Thank you, everybody, for such a robust discussion. I appreciate it. We're going to wrap up here now, given the time. And we would love to invite everybody to our next speed session that will be held May 24th. And that is going to be a discussion of the appropriate use criteria. So hopefully such a great discussion like tonight's as well. So we will be having Dr. Ritu Sachdeva and Dr. Howard Hetching as our discussants for that topic. Have a good evening, everyone.
Thank you.